Today's topic of discussion is understanding patients' expectations. So if I may ask you a question, what do we understand by the term patient's expectations? You can unmute and speak, maybe one or two respondents can answer this question. What do we mean by patient's expectations? Yes, Dr. Lata, please go ahead.
That is with respect to the disease, how it's going to progress. That is, they want to know how long it is going to take for them to become better, and what are the prognosis and those kind of things. That is one of the expectations.
Okay, that's one of the expectations. So
what are treatment options? What is the disease? The treatment options. And its prognosis, and how are you going to deal with this? And also they want us to be gentle and very empathetic, and to be frank also.
Thank you, Doctor. I think Dr. Vasudevan has a point to add. Please go ahead, sir.
They want to be treated cured of the disease for the minimum cost factor at the cheapest rate and comfortably.
Yeah, I agree. I understand completely. Yes, Dr. Menon, you have a point to make, I think.
The expectations are with regards to what constitutes treatment, what services are being provided. So often there may be a mismatch between what we see as service and what they think should be part of the services. So often there is a mismatch.
Absolutely. And I think there's a lot of mismatch. There's no doubt about it. There's a lot of mismatch. And I think the whole conflict is around, mismatch in the expectations the patients have and what we can fulfill. Thank you. I think that was a good point. Yes, Dr. Asha, please go ahead. Yeah.
One expectation is on the treatment side, on the interaction with the doctor side, with the financial side. Like in any service, once they pay, they assume that they get the best services, so that it is an assured result is what is the expectation. To understand that this profession is not like in any way, you cannot guarantee results, is not in the framework of any human being, I would say. Even when we are patients, I think the scenario would be like that. We expect something 100% new. So that is where the gap between the expectation and what you deliver is there.
Absolutely.
But it varies from patient to patient also, because suppose I tell a patient that she is having a tumor, or suppose it is not malignant, but suppose she has got a mass, fibroid. Some patient wants surgery, some patient doesn't want surgery, some patient wants conservative management only. So the expectations vary. Some may be very anxious about the disease. They want to get rid of it at any cost. Like that, it varies from the patient to patient also.
Absolutely. Thank you. I agree with you. Yes, Dr. Harimohan, you wish to make a point.
If I talk it in a very generalized way, I think any two people requiring a service and the one giving a service has got expectations which is going to be different. Like if I go to a hotel, I would expect something and the hotel owner would expect something else. Similarly, a patient also has got an image in his mind of a doctor who is going to be telling what he likes, making him pay what he wants. In all ways, it should be exactly and making him understand clearly. And the doctor also has some expectations of the patient, how he should be. And what we do is try to bring down the gap between the two.
Thank you. I think that's a very good point. Yes, Dr. Paul, you wish to make a point. Please go ahead.
As a patient, the expectation will be like if it is a disease that will be cured by this person, and he is one of the best doctors, and the confidence should be there for the patient, so that he proceed, and also he'll be compliant to whatever treatments we are doing.
Absolutely. So you can see we are quite aware of what my patients expect. There was a time, maybe if I talk about 30, 40 years ago, probably patient expectation was that treat me, that's all. Examine me, give me medicine. If you think I need to be operated, please operate me. That's all. That was a very basic kind of expectation the patient had from us. But with the changing times, especially when the patient started paying for the service, there came the idea of value for money. Then there came the idea of, okay, please assure me that will give me good results. Then there came the idea that, okay, communication is important because patient wants to participate and want to know and want to participate in decision making. So you can see with changing time, the expectations of patients have really changed, are changing, and then people are aware of those expectations. And also, when patients pay, sometimes they compare healthcare delivery system with any service provider. So we know that you cannot exactly, compare, but then we can't stop the people from asking this question that if I'm paying that, why not I get this service? It is not just about the outcome. So maybe you cannot assure them of the outcome because we have no way to assure them. But at the same time, like things like patient safety, patient communication, cleanliness, hygiene, all these things can be assured. But sometimes we fail to even assure those things. And that becomes a source of conflict between, patient and us. And also when it comes to unrealistic expectation, like when patients say that give me guarantee that I will be 100% all right. I think we need to address those expectations rather than being annoyed with it. Because somewhere we are responsible for increasing their expectations. So can you give some examples where you think we kind of deliberately increase their expectation and then we say patients have unrealistic expectations from us? Can you think of some examples?
Suppose a patient is having a disease which cannot be 100% cured.
Mhm.
Like a tumor or something, it has got its own prognostic factors. So we cannot give 100% result for them. For them, they might think by chopping out the uterus, they will get rid of the uterine cancer. But that is quite not possible. Like.
So yeah, I want to give you a live example. This patient is, under counseling with me. So this lady, she had she had OCD issues with her urinary, problem. So she went to the toilet frequently and, came out and then again going in. And that was the pattern that she was doing. She went to a gynecologist who said, okay, it could be because of your uterus. Let's remove the uterus and maybe your problem will be solved. So she got her hysterectomy done and the problem is still there. So sometimes when we fail to communicate clearly that what we are saying, if that doesn't happen, then where do we stand? A lot of taglines that you get to hear: come from home, get the surgery done, go to your office. If you remember, this was a tagline. I saw it in Delhi. I'm sure you must have seen in your state also for ophthalmic cataract surgery. Come from home, get the surgery done, go to your office. So when you give such,
False promises.
yeah, I wouldn't say false, but then it's not risk-free.
Exaggerated.
Yeah, it is not risk-free. Or even, for example, for knee replacement, if you say that after knee replacement, you will be actually able to climb 10 floors, and the patient is actually in pain for good, 6 months, then they feel that they have been not given the correct information or they have been cheated. They even go to the extent of saying this. Or, for example, I remember I sent a relative of mine, who a very good friend of my husband, who is a bariatric surgeon. So during surgery, a lot of things he did not, before the surgery, a lot of things he did not say. When I met this patient, she said, I said, are you happy that you have actually reduced your weight and a lot of comorbidities have gone down? She had migraine, she had diabetes, she had hypertension, she had hernia. All these 3-4 problems got, actually sorted. She said, I'm little upset. I said, what? I said that I was not clearly said that you will not be able to eat as much as a normal adult eats. I take one chapati, and if I take a little bit more, I throw. Or she had to spend a lot of money on buying supplements every month. So when we do something like this, then patients feel that we haven't been given a very clear message. So patients expect more transparency and honesty from us, clear communication, telling that, okay, this is what it is. So I think at one point of time, even we are responsible for the chaos that we are seeing. Yeah, Dr. Raki, you had raised your hand. I would request you to say if you have something to add. Yeah. Dr. Haribon after her. Yes. Go ahead, please.
Yeah, actually, what Indu ma'am just said about the ophthalmic part, I think now what happens is all these corporate setups, they have kept counselors who will sit there and, they will tell you all overrated things about, what each lens could do. But these are all theoretical things and it differs so much person to person, These counselors, they must be MSc people, BSc people. They know only the theory part of it. But actually, when it comes to that lens into the eye, it differs. In one patient, maybe it must be right, but the other person, it might not be.
Yeah.
So that way, I feel what ma'am said is very true, because
I completely agree with you, Dr. Raki. Incidentally, I am involved with Orbis International and I'm training their patient counselors. So 2022, it was not 22, 21. It was completely a virtual program. I had not visited any hospital. So I was doing this training, online, and I could see that those patient counselors were meant for only doing the booking by giving, all kind of, expectations that you will have this vision and that comfort and discomfort. And their primary aim was to book the case for as high price as possible. So we had to work on making them unlearn this. And also understand the counselor is not just for the hospital, counselor is for the patient. This time, 2022 and 23, I went to both the hospitals. These are the two partner hospitals of Orbis International. One is HV Desai in Pune, and the other one is NNN Hospital in Kolkata. So I personally visited both these hospitals and I did 30 hours training with the patient counselor, where I help them understand that even when you are telling that, okay, this is the benefit, be very honest and don't kind of go with the mindset that, okay, I have to make a, higher booking or a bigger, package. Always look at it from the patient's perspective and then you offer. Usually patients, start having that faith when you are honest and transparent. I think that is one point. And I have received this feedback from the administrators that their conversion rate has gone up. Patients are, going for a better package, but with a lot of clarity. I think that's what I think we need to address. Yes, Dr. Harimon, you wish to say something. Please go ahead.
I'm just telling a few, same thing, what Dr. Raki said.
Yeah.
Too much of corporatization and competition makes them do it. I feel the suggestion would be, like in abroad, any such counseling is always done as a team.
Yeah.
So there is a medical person, there is a professional counselor,
yeah,
who are good in their own skills. A medical person will not be good in the skill of a counselor and the other way around also.
Yeah.
So when they are sitting together as a team, this kind of discrepancies can be avoided.
But Dr. Harimon, that is something doesn't happen, in a regular way. You will see a patient going to the doctor, getting all the consultation done and, getting all the prescription. And usually the doctor will say, go and meet the counselor. So a patient would go to the counselor's room. So the counselor has to actually know a couple of things. One, should have the understanding of the basic illnesses and the treatment modalities. So therefore, I chose optometrists and ophthalmic nurses who had some foundation in, optometrics.
Very true.
And, yeah. Then is, of course, I enhanced their counseling and communication skills, where I made them, learn how to build rapport and how do you really, break ice and then address the patient's concerns and answer their questions. And then also, how do you go about being very honest and transparent in your approach so that patient don't feel cheated that we have been, fooled by the team of doctors in the patient house. So they really, and also they should know the frequently asked questions and the answer that the doctor expects the counselor to say, so that there is no, dichotomy in what you say and what the doctor says. So this is the modality I've, worked out with them. I can see two hands, and I think I just allow both of you to please speak, and then we'll move on to the topic because we have yet not started the topic. Yes, Dr. Nambiar, please go ahead, sir.
Basically, I'm a pediatrician,
Hmm.
and I've seen a lot of cases like, the cerebral palsies, one 10-year-old girl was there with
Mhm.
cerebral palsy and leading a vegetative life, in fact. And that mother was highly expectant.
Mm,
She thought that the baby would improve and
mm,
come to normal life. But then how to explain to her, that was my problem, very
mm.
difficult because totally a vegetative life for the girl. And still, I was finding it difficult to explain to that mother.
Yeah.
So that's the question I want to put.
So I think that's a very, 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 very good question. I mean, I can go into it and help you, understand how exactly we have to go about. But this topic is going to be covered in the, sessions that we are going to take. For example, this is more like breaking bad news, where you're going to tell the mother that
Yeah.
the baby is not going to improve, the girl is not going to improve, and they have to learn to, see how they can make the quality of life better by providing whatever is possible, and how can you really rehabilitate the child, or what faculties can be enhanced or utilized so that child can lead a productive life in some way, although I know the challenges a cerebral palsy child would have. So how do you do that? Maybe when we take breaking bad news, you can bring up this case and we could actually do a role play around it, and then I could give you a demo on this, how we can go about doing it. Because this requires detailed working. There are steps what you need to follow, and then how do you communicate? Maybe you act as a mother of the girl, and then I act as Dr. Nambiar, and then we discuss this case. We will
Okay.
do this
Okay.
when we
Thank you.
do that session.
Thank you. Thank you.
But thank you for being with us. Yeah. Yeah, Dr. Sonia, I think you wanted to say something.
Actually, I don't know whether the advertisements fall in the purview of our discussion, but the advertisements are absolutely unrealistic, and corporates have lot of advertisements, and they speak of very, very unrealistic things, as you said, like about knee replacements. In fact, Tamil Nadu, I've heard a jingle where you have one organ removed and then removing another organ is free. Appendicectomy
Oh, my
and one
goodness.
cholecystectomy for one appendicectomy. So these kind of things, even for the general comprehensive health checkups, they have big, they make a big fuss out of it actually, that they will pinpoint everything and you will be disease free henceforth. So these kind of advertisements play a big role, and one cannot probably fulfill as a medical personnel. It's very difficult to fulfill those expectations.
So thank you for bringing that up, Dr. Sonia. And I think we do realize that we are somewhere responsible for raising their expectations. We have to take that responsibility, and then we have to face the repercussions when their expectations are not fulfilled. Similarly, I think expectations from a government setup are little different. Patients coming to government setup have a different set of expectations. Though it is minimal, but then it is there, and then sometimes when it is not fulfilled, they also become aggressive and upset. So I think before we go further in discussion, I had shared the complete document once again in the WhatsApp, so that those of you who have not gone through the document, I had asked you to read page 31. So which was more like a
33.
33.
33. So I hope all of you had a look at the case study.
Yeah.
So if you have read it, I will not ask you to. Anybody who has not read it? Anybody has not read it? I have a very responsible audience. I'm so thankful to all of you to have read it. So I think I'll immediately, rather than discussing the case study once again, I'll quickly go to the questions that come to our mind. I think one question that I want to ask, I mean, where do you think was the communication failure in the whole process?
The doctor didn't explain to the wife the exact problem. And he should have explained to the wife that the patient is under observation, and they will give their opinion after say 1 hour or 2 hours, like that. So they didn't explain anything and they went off. That was the reason for that confusion and bad reaction.
Thank you. So if I may ask all others to, think and tell me, is this something, not a very regular thing? Isn't this a very usual
It
thing?
is. It is.
Very
Yeah,
common.
quite often.
It is.
Very common.
It is quite often. So I think it should open our mind to the idea that if you're seeing a patient, just imagine a patient has come in pain. Now a patient with pain in the left shoulder or left arm and the chest, what is their fear?
They want me to have
Some
a
heart problem,
attack.
heart attack.
Heart attack.
Some heart problem. And if you have examined, what is their next expectation from us?
An ECG and
Okay, I think everything was done. He even put the monitor and he was okay with the idea that ECG is fine, but then he still wanted to keep the patient for observation, which is perfectly all right. But what was the family's expectation?
We tell them,
Caution them that it
doctor
is
would
not
explain
at
his
present.
Now, if we put ourselves in the patient or the family's position, if I have taken somebody to the hospital with pain in the chest, and if the doctor has seen, my first question will be, is it heart attack? Is this something to worry about?
worry about.
Is it something serious? So I think these small things, if we can, and incidentally, we all do everything in the patient care. I wouldn't say we fail in doing the immediate care that the patient requires. But when it comes to communicating with the family, we think that is secondary, or that is optional, or that's not required. So what happens? You do everything in the patient care, but you don't communicate with the family. So it is something like winking at a girl in dark. You know she does not. And it is so important to let the family know. I think that's one thing that will allay the patient's anxiety and the family's anxiety. Okay. So even if you don't want to if you're not even completely assured, sure of, one second, I can see some of the answers, so I want to read them. Dr. Asha says, reassured that it is not an attack on preliminary, but we have to monitor, or the plan of action should be brief. So exactly, if there is a possibility that you're not sure what it is, it's all right. If you just say, it doesn't look like heart attack, ECG seems to be okay, but we still need to do some more tests to be 100% sure that it is not heart attack. We are not gods that we have to give a one-line diagnosis. Nobody expects that. And we probably have this expectation from ourselves that we need to have, immediate, accurate diagnosis, which may be possible, which may not be possible. But what is the harm in saying it doesn't look like heart attack, but we need to do some more tests? Or yes, it is something we need to further check and be very sure what I'm going to say. But that means some communication has to be made. And when you don't communicate, there is assumption. Not that the patient will not think, but the family will not think. There will be assumption, but somebody might think it's nothing serious. They are not doing anything. So we are just made to sit here. They are just making money by admitting me here. They are not doing anything. That can be one assumption. Second assumption, like for example, in the government setup, the assumption could be they are not doing anything. They are not serious. They don't care for us. And this assumption is usually the basis of the aggressive reaction that we receive from the patient. Just by clearly saying that this is what it looks like, or this is what it doesn't look like, and this is the plan of action. Like one of you mentioned already, some brief plan of action. Okay, it doesn't look like heart attack, but I still want to put him under observation so that we don't send you back and then have any trouble. Why not? Then what happened after? I can see one more answer in the chat box. Allow me to. Even the sister can brief me. If she can, there's nothing wrong. But if she doesn't and she is okay, let me check with the doctor and then get back to you. Even that is doable. Normally, we don't expect the nurses to do the briefing because we feel that there can be a confusion. So it's okay if she just at least says, okay, I'll mediate for you. I will advocate for you, because we expect the nurses to advocate for the patient. You could go and speak to the doctor and say that they seem to be apprehensive. If you can just go and explain to them. But what exactly did the nurse do?
Yes, she complained regarding.
She
Instigated.
twisted the words.
Yes, instigation then.
Instigator, yes.
Tell the doctor.
She twisted the words. So what happened? 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 She
The doctor
The doctor got irritated.
For a not-
And
Is there any channel?
Sorry?
yeah, doctor got irritated actually.
Doctor got. Now we may say doctor got irritated because she said something like this. But as a responsible professional, are we not supposed to be, careful
Yes.
of what we say?
Sure.
And can I blame the nurse or the patient or the patient's family member for my misbehavior?
No.
So I think somewhere
Neither for
respect,
his words.
somewhere respectful behavior is also one of the, expectations the patients have from us. So if we take this example, one is that, clear communication, some briefing, some plan of action, some update. The nurse
Updates.
went 2-3 times.
Kept going,
The-
yeah.
But madam, I have just a small difference of opinion here.
Sure,
It is
sir.
true that the doctor should have explained. It is also true that the sister should have gone and examined. She just peeped into that room and then walked off. She could have told them that everything is fine, everything is all right. But the problem which we all face, see, they came rushing to the hospital when they had acute pain. The doctor did everything for them. At least while going, they could have asked, doctor, is my patient all right? Can we go, or what should? She just said that they are not doing anything, so we'll go. So I think they were a little ungrateful to whatever has happened. Maybe communication breakdown is there. I'm not saying that there is no breakdown, but the patients also have
So, Doctor,
a responsibility of their communication is equally bad, is what I have to say. It's not only one side of the coin.
Vasudevan,
We are
I
we are
completely agree with
professionals.
what
We
you're
are
saying.
trained for it.
But we have to remember we are trained doctors, they are not trained patients. So that is one thing. Second is they were having a conversation between them. They did not go and tell this in the same manner with the doctor or the nurse. So she went to they were having this conversation and she went and told the nurse that if you could check, nothing is being done. So can we go if it is okay? The nurse twisted the word. This is a very human, very regular kind of a mindset we all have. When we are unhappy about something, we go and twist the word and say in our own words to the next person. So that person also reacted. So you can see the breakdown happening at all levels. I agree. Patients misbehave, patients are rude. I'm not denying that fact. And I personally have had a lot of experience sometimes when patients misbehave for no reason. But again, how do I want to handle that? That's something that I have to learn. So we will be talking about it. How do you assert without being aggressive in a situation? We are going to talk about this in the next session. But if I may just tell right here that proactive communication from our side has to begin. Promptly, we have to update the family. Normally, we do everything, but we think medical intervention is our prerogative. Patient has nothing to do with it.
Madam, that lady went to that room. The Zenith went to the large circular desk in the middle of the room and asked a nurse if it was all right for Abdul to leave, since they had been in the room most of the time alone for quite some time. Actually, that was being. I think they also have an equal responsibility of provoking people, because when as doctors we do a lot of things.
Dr. Vasudevan, I think this is just a case study taken with the idea to learn how can we improve our communication. That's the whole idea. And where are we failing? What can be done to, make things better? That's the idea. Of course, I understand that patients also should be told how to, behave or communicate. But then easier is to train us than training the whole population. That's the purpose of this assessment, that we learn how can we fill in the communication gap, how can we make things better. So I understand what you are trying to say. So I think this case study tells us that there is a lot of communication gap. Let's have a look at the presentation and then we'll talk about how can we make things better. Let me share the screen with you and take this discussion further. Okay. So according to a recent study by, ICC, CRMMA and Taragani, in India, 45% of the families reported feeling unempowered in the treatment of their patients because they felt that they didn't have much role to play in the patient's treatment. They also expressed inadequate clarity on diagnosis, reported the consultation to be rushed ones, and they perceived lack of involvement in deciding the treatment and lack of clarity on treatment and care options. In this same study, 35% of the patients indicated that they were not allowed to describe their conditions or symptoms in a proper manner. Also, they felt that their questions were not addressed straightforwardly by the attending doctor and their doubts were not clarified. Almost one third of the patients had this. So that means there is a gap between what we communicate and how much we communicate and what the patients expect. As I said earlier also, earlier patient did not expect any or much communication from us, but now there's a realization that patients expect us to talk, explain, involve, engage. So it's time that we understand this expectation and see where all can we actually fill in the gap. So for example, patients expect to be allowed to narrate their problems in their words and to be heard attentively. And we have seen a lot of doctors who would not let the patient speak, or they will snub the patient and not letting them, complete what they are saying. And especially if the patient is talking something that is not relevant, patients actually are snubbed literally by saying that don't talk of something that happened 10 years ago. Talk to me, what is the problem right now? We have discussed this earlier also, that on an average, we interrupt the patient almost 11 seconds of the interview. When patients start speaking, we kind of, quieten them, or we start asking them a leading question or closed-ended question, because we think that if I ask the question directly, I will be able to save time. We don't allow them to narrate their problem. And if we allowed, any idea how much time they would take to solve their problem? I think we have discussed this earlier also. Now you have some fair idea.
I think about a minute.
Almost a minute, exactly. In a minute or two, actually, they can talk about their problem. And that gives them a lot of satisfaction that the doctor has heard me. So I really like this quote, so I am sharing with you that there is no greater agony than hearing an untold story. So when you raise your hand and you want to make a point, and unfortunately, if I miss your hand and if I don't allow you to speak, I'm sure you must be feeling very, upset that I couldn't say what I have to say. So same way when patients come to us, see, if they're coming to government hospitals, usually the waiting time is very long. So almost for 2 to 3 hours, they wait to meet us for those 2 to 3 minutes. And if we are not able to, listen to them or allow them to talk, they go back with the feeling that I have not been able to talk about my problem. In corporate setup, where we are charging them quite heavily for the OPD charges or the consultation, and there when they are not allowed to talk about their problems, they feel that I paid for the service and I'm not, allowed to talk about my problem. Patients also expect that we will explain about their disease, diagnosis, treatment, or intervention in a simple and understandable manner. Whereas studies suggest that we use a lot of technical jargon, which sometimes they don't understand. So as a result, they don't get the exact meaning that we want to communicate with them. I'm showing you a paragraph. I would request you to read this paragraph carefully. So what did you understand?
Yes.
Could not read completely.
Could not read.
No,
This is what exactly. This is what exactly happens when we explain our patients about their diagnosis, treatment, intervention, or prognosis. 50% of the patients and family do not understand much when we explain them about their illness. This is not me, but these are a number of studies that have shown. That means it's more like a rushed kind of explanation. We don't check how much they have really understood. Studies have shown that when we explain, the graphical display could actually benefit the patient. If you could explain them in a manner, when it comes as a visual, they will understand it better. They will understand the risk and benefits. So definitely their information need would be satisfied and they'll have a better understanding of their condition. In another study, actually it studied almost like, I think, was it this one or the previous one? The previous one, they actually studied 28 studies to see what worked best, and they came up with this conclusion that the graphical display could actually benefit patients understand the risk and the advantages and disadvantages. Even if you could draw on the patient's case sheet, even if you could draw on the consent form and show them about their disease progression or some obstruction or enlargement or constriction, I think it will make a lot of sense for them to understand what exactly is the state of affairs. This is another study where they tried to, Dr. Paul, you wish to say something?
I just wanted to know the difference between this drawing and this graphical thing that you have to.
Difference between drawing and
Graphical display.
Yeah. So, for example, if you are sharing, say, for example, for IVF cases, if you want to say that, only 1 out of 4 are actually able to conceive. So, if you can show them in some pictorial form that 1/4 of the population who come for, IVF treatment get to have kids or have to conceive. So, they get an idea, okay, my chances of conceiving are almost like 1/4. So that is graphical. So a lot of data can be displayed in the form, graphical form, but there are places where we don't have access to this information. At least whatever, treatment intervention you are doing, if you could even manually draw and explain, for example, some constriction or dilatation or enlargement, they would have an idea, okay, this is the size, the original size of the organ, and this is this large it has become. So they are able to understand the concept better. That's what I'm trying to say. So similarly, this is another study where they tried to find out that what is the information need and how much it is being provided. So actually, they found out that there is some substantial variability in the information provided, and they also realized that we need to improve the quality of information provided to allow the patient expectation to be more appropriate and maximize the outcome. The idea is that if we understand that if we want to handle patient's expectation, we have to provide them information, evidences to let them have more clarity on what can be expected. Yes, Dr. Harimohan, I think you have a point to make. Please
They make it very fast. Like most of them, even in symptomatology, like for example, pain. If you tell
I'm sorry, I'm not able to hear you clearly. Yeah.
No, if we are able to tell them what causes the symptom, they are more happier. Like, for example, if they come with severe gastritis or low stools or even pain, and if we find the pain is due to colic, if I try to explain that more clearly, the cause for the pain, the cause for the symptom, in my personal experience, I found it very useful. They generally accept it better.
Absolutely. The more information you will provide, more clarity they will have on the even prognosis. They will understand that sometimes if it is irreversible, if you are able to explain them why it is irreversible, they will ultimately accept and they'll move on. Then they'll try to find how they can make things better. I completely agree with you. Yes, Dr. Raki, I think you wish to say something. Please go ahead. Yeah.
Yeah, especially regarding my department, ophthalmology, my HOD used to say there is nothing ambiguous in ophthalmology because you're seeing everything. We take pictures, you take picture of cornea, if there is an aberration, nowadays in my OPD only, I take pictures and show it to them. So they're like, so happy to and I tell them like, what is the prognosis? The next day I take the picture again and show them. So that clarity is there. So I think I'm lucky to be an ophthalmologist.
Absolutely.
And I think not gynecologist.
So yeah, the more information you will provide, it will be easy for you to fine tune their expectation. So when you are able to say that there is a retinal detachment, for example, and this is what retina does, and that's why you are not able to see clearly. And even if we do this surgery, there is a risk of this disease factor. One, now they have access to Google, and almost all of them will go home and read. And when they will read the same thing, what you have said, they will know that you are not fooling them. You are telling them the truth. And then they can go to any length to read that. But that's the thing I'm saying, that when patients have unrealistic expectation, please fine tune. Please identify and fine tune, and you will see patient becoming realistic in their expectation. Most of the times you can actually, explain them and help them understand what exactly can be expected. As I said earlier, also they want to know in detail about their illness. There was a time patient never wanted to know what it is. They even said, "What have I to do? I don't understand this term. I don't know the medicine. You are a doctor. You know what is my diagnosis. Please treat me the way you like." But today they want to know what it is. They want to understand how is it going to affect my life. What is my life expectancy? How is it going to impact my quality of life? So when they want to know all these things, that means we have to be ready with explanation. We have to be ready with data. We have to be ready with that much of time and patience where we can answer this question. So in this study, for example, that I'm sharing with you, almost 100% of the patient wanted to know if it is cancer or not, and almost 87% of the patient wanted as much information as possible. So this should tell us that patients are evolving. So are we supposed to evolve? Again, for example, we never involve them in decision making. We always operated from the paternalistic style of medicine, where we would decide on the patient's behalf and patient would blindly trust. But there is a realization that how much ever you are doing in the interest of the patient, but still we have to give them the option to say no or yes. So they want to be involved in decision making. Some of us have started practicing that. We share now, for example, this patient, this patient this case that I shared with you of bariatric surgery, had he explained this information to the patient that this surgery is going to give you this benefit, but this is where your diet is going to be cut down. You will not, because we are reducing the size of the stomach to reduce your weight, so you will not be able to take like an adult. You will be able to take almost like half your diet, and to compensate for that, you will have to take supplements for some time. And these are the things I'm sure even then patient would have. But some of us think that sharing information or shared decision making is not appropriate in every situation. For example, you're an ophthalmologist. Enucleation in certain situations, when that's the only choice, for example, if it's a case of retinoblastoma, enucleation is the only choice. We have to help the patient and the family understand why do we need to do enucleation. And when you explain them that it is to save the patient's life or it is to save the patient's other eye, I am sure they will be thankful to you to have explained and guided them. So I think the whole idea of that shared decision making is not appropriate. I think we do not know how to go about handling that situation where they resist and then they ultimately finally agree and understand and give their consent. That process can be very lengthy, but it is not impossible. And I'm sure we'll do certain role play. I would ask you to take as difficult situation as you want, and we will discuss on that, because ultimate aim is that the patient is not understanding. I have to go down to the level where I help them understand. See, I am with you. I am for your patient. I want your child's life to be saved, and that's the only option we have. And when you practice something like this, I'm sure you can engage them and involve them in informed decision making. Again, patients expect when issue is sensitive, please handle it carefully. Unfortunately, a lot of studies suggest that we are not really very good at difficult communication. When it comes to breaking up bad news or talking about end of life care or grief counseling, we sometimes fail at words. We fail at handling emotions. And that's what studies suggest. So that means we really need to upskill our skills of handling difficult conversation. In case of any error or complications, patients expect us to give them complete information. Tell them what happened. They want us to be honest and transparent. Most of the times we think if we share everything, patient will either sue us or we'll have a legal case or some violence would break down. But if you don't tell, your staff is going to tell. Let me tell you. A lot of time we have seen your assistants and your nurses or your housekeeping staff will go ahead and tell that this is what has happened in your case. We say that yes, we should be disclosing, but honestly, only 30% of us do the honest disclosure. Most of us, try to cover up the case. Also, patients' expectations are not a rocket science. Only thing is, can I identify what my patient? I think one thing the patient expecting ease of communication. They want somebody from us to listen to them, talk to them, somebody who can, answer their questions or address their concerns. For example, if you think you are overworked, you don't have, time to do that, you could have people working for you. It could be patient counselors, it could be your, it could be your nurses who can be trained. For example, in diabetic clinic, they have appointed diabetic nurses. In psychiatric clinics, they have appointed psychiatric nurses. So if you can train them, if you can guide them how to really explore patients' concern and answer those concerns, I don't say all questions have to be answered by doctors. I know you would like to focus on more important things, but then don't say that I don't have time and I can't do this thing. So have somebody who can, complement you, who can supplement what you are doing. But patients' communication needs have to be addressed, and that is the primary reason for the discord between us and the patient. Then patients expect compassionate and empathic behavior. So they want the staff to be, treating them with care, concern, and compassion. Very honestly, I always say, Jaisa Raja, Vaisi Praja. If you set a right example, if your behavior with the patient is cordial, you are kind, you are compassionate, automatically it will trickle down to your staff. They will know that you don't take nonsense, you don't misbehave with your patient, you are very cordial. But you can see it for yourself. Those of us who are rude or authoritative or intimidating, you will see your staff also would be misbehaving with your patient. So I'm sure you can give me a number of examples of on this scale. Then patients want access to information. So there was a time when patient's case sheet was our property. The moment patient tried to touch the case sheet, we said, no, you can't touch the case sheet. And case sheet used to be actually with us under lock and key with the hospital staff. But with changing time, I think everybody knows patient has full right to the patient's information. And whether we like it or not, if they want a copy of the document, we can't say that no. It's one of their rights. So they want to clearly know, what is happening, why it is happening, what is they want verbal information, and even if they ask for information, I think it's time we will have to let go of that. They want prompt attention to patient's health needs. I think pain, bleeding, unconsciousness, these are the conditions, or for example, labor pain or some acute condition. That is where they equate attention with expectancy of life. If the attention is delayed, they think because of the delayed attention, the patient died or patient has something. So I think this thing we have to seriously understand, even if we know the patient is not going to survive or whatever the case is, we have to pay prompt attention and make sure that the family goes back with the feeling that enough has been done to save the patient's life. A lot of times we fail to communicate this, and they kind of think that we are not doing enough or we haven't done it. Of course, safe and comfortable environment is one expectation now patients are very, particular about. So there was a time when we thought it's just the patient who needs to be attended. So we never cared for having any waiting room for the attendants or the toilet for the attendant. I remember around 35 years ago, I went to see my husband's aunt at Escorts Hospital in Faridabad. So she had a cardiac condition. She had gone there for angiography and then angioplasty. So when we entered the Escorts Hospital, I felt I'm in a 5-star hotel. I was really, I mean, honestly, very honestly, not only I was astonished, but I said, what a waste of money. They have created waiting lounge, they have a coffee shop, they have a cafeteria, they have a bookshop, they have a gift shop. I said, what is it? Are they looking after the patient or what it is? But I think with time I realized, and I'm sure you would agree with me, when the patient is in the hospital, I would say patient is far more comfortable than the family. Patient has a bed, patient is getting medical attention, patient is getting treatment, there are people to look after. It is the family who is suffering more than the patient. They are waiting outside, there is no place to sit, especially if I talk about the government setup. Where we don't have much arrangement for the family. But today, of course, we are realizing when the family has come from a far off place, They have nowhere to live. Now we are trying to arrange lodge for the patient's family. We are trying to arrange waiting areas. We are trying to create comfortable places where they can sit and lie and rest. And that is what now everybody is trying to do, because we know our client is not just the patient, it is the patient and their family members. And both have to be looked after. It is never usually the patient who would come fighting with you. It is the family member who will be coming to fight with you, because they are distressed, they are tired, they are exhausted, they are financially, in trouble. And plus, they have a family at home who needs to be looked after. Maybe small kids, maybe an elderly parent, and they have to manage between, one place to another. And they have a job, they have a livelihood. You can well imagine, what must be their state of. So not only for the patient, but I think for the patient attendants also, we have to consider that they require a safe and a comfortable environment. Yes, of course, I agree with you. There are some unrealistic expectations. Can you name some unrealistic expectations that you think patient would have in the chat box, if you could write? Wow, Dr. Asha, you have written a wonderful, message in the chat box. Patient's behavior come under circle of concern, and our behavior comes under circle of influence. Thank you for remembering, and also, bringing it at a right point of time. We need to focus on ourselves, because that is something we can. Thank you. I really appreciate it. So I request all of you to write some unrealistic expectation that you have experienced and you think that needs to be managed. Complete cure. Yes. Total cure. Yes. Both of you have written the same answer, Dr. Lata and Dr. Arjun. Agree. Yeah. Again, the same answer. Dr. Rajalakshmi has also said the same thing. Their disease will be fully cleared through, though they are really sick. Yes. Yeah. No complications and no symptoms left. Correct. Speak to each bystander. Yes, Dr. Mini, I think this is something we can address. And Dr. Mini, what have you written? No. Can you unmute and answer, Dr. Mini?
Yeah. As each bystander came on as soon as the patient is getting admitted in the hospital, the bystanders will keep changing, no? And even if we are explained to one patient, one bystander explained everything in detail, the moment we move to the other place, another one will come and ask. So we need to explain to them also. We can't say, I already told to your husband or to your wife or your child, then how can I explain to you? Because we also become irritated. We have to take care of the other person also.
This is doable. So, this we can handle. We'll talk about this.
Yeah.
It's like interesting, this thing. So everything will be okay. Again, I think all of us have a feeling that the patient expect total recovery. And then they want to know the time frame for relief. Yes, Dr. Lata, you wish to say something. Go ahead, please. Please unmute, yeah. Unmute your device.
Explaining to more than one bystanders, again, it depends. I think if we should make a policy that adult patient, usually they have the right to know about their disease, or the nearest relative. It's like some far relative who is basically not interested in the real welfare of the patient, but just want to know and spread the news to others. So I think if we make a policy, it's only to the next of kin we are going to say, or to the patient, and then we can convey the same to them that we have already explained to the nearest relative. That may be a better option, because if we keep on, it happens for me also. We finish all the rounds and we are coming out, some new relative comes and will ask what is the condition of that patient. So it may be some neighbor, somebody.
Thank you for bringing that up. So I think you have rightly said. I would suggest that whenever you admit a patient, write the name of the primary caretaker and the phone number of that person on the patient's case sheet, so that you know that this is the person with whom I am going to talk. That is one thing I can suggest you. That will help you to clearly know whom I have to talk to. One. Second, I would say make it a practice to update the patient's family maybe once or twice a day, whatever fits your schedule. So you can say that, okay, we'll be briefing you about your patient condition, morning and evening at this time. So they would know that this is the time they will be briefing. The third point, when you brief the primary caretaker, and then when you say, okay, do you have anybody who wants to come and listen to your discussion? And if they say, yes, I have my uncle, so you can say, okay, don't get all of them, but maybe 1 or 2 persons if you think who are really concerned about the patient condition, you can call them. And then when you have all of them and you talk to them, spend 5-7 minutes, I think not all patients are very serious and not all family members want to go. It's usually when the patient's condition is not improving or when we know the prognosis is poor, that is where the updating is very, very important. So talk to them, explain to them, and there's a last distinct point you must say, now I have explained you everything. I request whoever comes to ask about it, kindly handle it. And if you think that they should really meet me, then whenever the next update happens, please call them. So you put the ball in their court rather than, answering everybody. Plus, sometimes we become rude, we become aggressive. I can't handle this. How can I explain to 10 people? I have so many patients. Do you expect me to talk to every attendant of it? That's not going to. But if you are following one, if you know the primary caretaker, if you update them regularly and then ask if there is anybody you want to involve in the discussion, and then as a last word you say that I have explained you everything, I've answered all your questions. In case if somebody comes in between, I request you to do. Or if somebody comes in between, if I politely say, see, the next update will happen at 5 o'clock. Please come when I do the update. So if he's really concerned, he will definitely come at 5 o'clock. Otherwise, he'll say, okay, whoever is available there. So what I'm trying to say, rather than getting annoyed, assert, and we are going to talk about it in the next session. I can see a couple of answers again, and let's see if we can identify any unrealistic expectations. So many of you have written complete care, total care, disease should be fully cleared, no complication, no symptoms. Honestly, if you ask me, and I rather ask you, is it unrealistic or this is how the human mind works? If it was our own family member, will I not expect the same?
Yes.
Will I not say, see, do something, whatever you can do? So that means that's how the human mind functions. That's how we live with the hope that some miracle happens and my patient, becomes fine and starts walking and becomes normal. So that means rather than being unhappy, if I empathize, I'm sure if it was my father, I would have expected the same thing from the treating doctor. I think I need to explain to the family that honestly, even I would have wanted your patient to recover, but unfortunately, things are in a very bad shape. And these are the reasons why, I can't give you this assurance. Again, it's all about communication. Then, yes, Sonia, Dr. Sonia, you're saying attention given within minutes. Yes, I agree with you, especially if the patient's condition is critical, patient is, serious or bleeding or unconscious, they will expect. Because as I said earlier also, they equate attention, promptness with, possibility or the probability of life. So again, this is how the mind functions, and we have to fine tune that. Okay. Most of the things I think, okay, to come in operation theater to be with the patient. Oh, Dr. Paul says this. Do you really get to see this very often? Dr. Paul, if you may please unmute and answer this.
Yes, no, not very often, but there are questions like that. More than that, coming into the ICU.
Yeah,
ICU is a restricted place.
Yes.
For that, like when we show to one person, then all others will come. They will say that I am related to this. Like I am also very close. But we cannot, as you said,
I'm going to
there will be only
Are you
one
talking about the
primary
ICU or
person.
OT?
No, see, it is more common in ICU. I'm giving you two different scenarios. But ICU part is more complicated.
More common. I think so again, I think we got to help them understand why they cannot be permitted in ICU. Rather than we being annoyed about it, that how can we allow you to ICU? I think we have to help them understand that ICU itself means it is an intensive care area. That means the patient is critical. If we allow you to be with the patient, your patient is likely to suffer more infection and more, complication. Plus, there are other patients who may have infection that can infect you. So again, if you are able to show them how they are benefited by following your instruction. If you can change the conversation in a manner where you can show them how their patient or they are going to be benefited by following your instruction, they will most likely agree. But again, it requires discussion. Again, if the patient's condition is critical, likelihood of survival is very, low. I would say allow the family to see the patient one time, because it could be the last few hours when the family can see their patient alive. Of course, with clear instruction, not everybody, just the closest family member. That also for a few minutes, going in quietly, not disturbing anything and coming out. So there, if you are considerate, they will be thankful to you for this gesture of yours. That you were kind, you were understanding. Because a lot of time we tell the family that no, it's not visiting hours. You have to come only during visiting hours. And unfortunately, by the time next visiting hours come in, the patient is no more. And they feel very bad that they were not allowed to see their patient. So we need to really evaluate what would work. Doctor at their, okay, Dr. Rajlakshmi says that patients want the doctor to be there as soon as they call for him. Yes, sometimes yes, but again, assertion will help you here. And it is not just the doctor. Again, here, I would say empower your team to deal with the patients and their family members, so that whoever goes and talk, they feel that, oh, this is somebody responsible. So when consultants shout at their residents and ill-treat them, or sometimes say you are good for nothing and you don't know anything, who made you PG and how did you get PG and how did you reach here? When we say something like this, we are not only insulting our resident, but also we are, taking away the patient's trust in the resident. Then your patient will always want you to come and talk to them. Patient or family member would want you to come and talk to them because they don't trust you then, or your nursing. So you have to really build their reputation in a manner that my staff is very responsible, they can handle all the things, they're very experienced, so that they don't trouble you and they don't ask you to. Okay, responses at any time of the day over. Yes, that's another common this thing. Normally, when people ask for phone number, it's a choice whether you want to give your phone number or not. But if you are giving your phone number and if you also say, I'm giving you my number, but please don't mind if I don't pick your call. If I'm in a consultation, if I'm in a hospital, I normally don't take. So it's better if you message me and then, give me time to, and if it is an emergency, calling or messaging will not have, it's better to come to emergency and get the treatment. So again, helping them understand that I won't be able to take your call at whatever point of time you want me to. Doctors available for them round the clock, Dr. Asha. Yes, I know now they are expecting something like this. I think having somebody there to guide or to attend is important. If you have your residents, if you have nurses who are trained well and if they can manage, they will be satisfied. But then you have to build that team where they are there. If there's a medical emergency, definitely they will expect somebody to attend to them. And if I have a private practitioner and if I've done during the day, if I'm managing everything, then I have to have somebody to look after when I'm not there. That's our duty. Okay, the expectation of the parents of a child with cerebral palsy leading a vegetative life seems to be a far-fetched. We pediatricians have to somehow tell them the truth. We face such situation too often. Absolutely, it has to be explained to them, but it is not what you explain, it is how you explain. One, helping them know what is the reality. So when we talk about breaking of bad news, you don't have to, create confusion. You don't have to go vague. You have to be very clear in your communication, but sensitive at the same time. Plus, focus their attention to what can be done in these circumstances. How can we rehabilitate? How can we assist the child? How can we facilitate child's quality of life? I think if you shift their focus to this issue, and also if you could share some examples where people, in spite of all adversity, have done exceptionally well, better than those who have normal kind of, body and normal functioning. If you can show them some example, that gives them a ray of hope that it's not that it is end of life. Of course, for parents, it's very, 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 traumatizing, very, very, very difficult to accept. But there's a very beautiful acronym that I use that you can use with this. I'm going out of the way to answer your question, Dr. Tanya, and that acronym is PEARLS. If you want, you can write down. It's an acronym with the name PEARLS, PEARLS. So use this acronym when you are communicating with them, and you can align them with you. P stands for partnership. So whenever you are talking to your patient, especially in these conditions, never say you or your child. You will say we and our child. Immediately you will have them on your side. Oh, my doctor thinks that I'm family to we and our child. That is P, partnership. E is empathy. When I say empathy, and I will say, I understand. I mean, it's a very difficult condition. Anybody in your place will be, completely devastated. I know it's very, very painful, but we have to face it bravely. We have to face it bravely. So you're partnering and you're empathizing. A stands for apology and appreciation. Apology, not that I am responsible for your child's cerebral palsy, but apology that I feel bad for you. I'm sorry that you have to face this situation. So sometimes inconvenience caused by the disease condition also, if you say sorry, they feel that, oh, you are understanding yourself. Appreciation, when you appreciate their efforts. You have been coming very regularly. I appreciate your concern for the child. I know and I can see you really want your child to do, to improve, to become better. So you are appreciating. Appreciation kind of acknowledges their efforts in spite of the fact that probably there's not much hope. So PEA, R is respect. Respect is when you respect their decision. For example, if the family says, if they sign DNR, or if they say we don't want to, resuscitate the patient, or we don't want to admit to the patient to the ICU, or if they say we don't want ventilator, or if they say we want to take the patient back home because we don't see him improving, and I think it's better if we take home and we look after the patient. So being doctors, we have a tendency to do everything till the patient dies. I would say let's respect patients' family decision. And when you respect their decision, let's see, you want to go Lama. I know it's not safe. It's going to, if you're risking your patient's life, but it's your call. So when you give them an autonomy, you kind of respect their decision. So that is R. And L is legitimizing. So when you legitimize their feelings, when you legitimize their action, anybody in your place will be, tired and exhausted. You are legitimizing. Only two things we don't legitimize. One is suicide, and second is violence. These two things we don't legitimize. Violence and suicide. Otherwise, you can legitimize any behavior that would give them a feeling that you understand their suffering or their plight. And L is support. So whatever support you can provide, whatever things you can facilitate for them, maybe referring them to the right person, or whatever rehabilitation can be done, in whatever way you can facilitate their care and improvement and outcome will be happy. And if you use PEARLS in your day-to-day communication, you're good to go. So I'm going back to the presentation quickly. So I agree, they may want to discuss a lot of problems in one standard consultation, or when it is the family who comes and talks to you, they may ask you a lot of questions that they have read at Google. And they will expect you to explain. So that can be very upsetting, that they have read somewhere and then they come and ask you. But then we have to learn to assert, and we will be talking about it. Then sometimes they will ask you to give prescription without a consultation. They will not have the patient. They'll say, this is the condition, please give me, prescription. Or they want to call the doctor, 24/7 for any problem. And they think that the physician will always know the exact diagnosis at the first consultation and start treatment immediately. So these are some of the examples I have written. I'm sure there are many more unrealistic expectations. How do you go about handling that? One, if you can clearly know when the patient is manipulating, you assert. And assertion we'll talk at length in the next session. So don't worry, we are going to talk about assertion in great length. So you have to learn to, really not only identify, but also handle that in a very assertive manner. So take a step back, assess the certain request when they're put forth, and see if you think that can be managed, is that doable? If there is something that is doable, go ahead and do it. Even if you have to, detour, or you have to kind of go an extra mile. If you think, plus if it requires exploration, it will actually enhance your communication. And then also when you're explaining them about, because that's the major, bone of contention, that I didn't know what it is and it was not. So when you're explaining, make sure that you explain in a very, very simple terms, avoiding all medical jargons, and then why you want to do this and why this needs to be done. Even some tests and concerns that you think patient has to undergo, why we need to do, I think that's more important than they'll agree with you. And then in case if they ask for a second opinion, if we happily accept that, please go ahead and please bring that, whatever you discuss with the other doctor, bring that to me, so that in case if I'm missing something, it will be a new learning for me also. And let that patient come back to you. And then as a last resort, if you think the patient is really, really misbehaving and is not, ready to mend his ways, you can refer the patient. We have the right to refuse. So you can always do if you think you are not able to manage. Now, we have seen these expectations. Some of the expectations we thought are unrealistic, but actually they are not unrealistic. Most of them are new because we are not used to it. And we thought that, that cannot be, that can't be the expectation, and why the hell should I meet it? So for our understanding, I have divided the expectations in 3 parts. It's a Kano model of expectation. The first expectation that you would see is more like a basic expectation, where the patient would, expect something, but they are not going to ask for it. And if it is met, they are not going to come and tell you, thank you so much, my expectation is met. But if it is not met, definitely they are going to be happy. So can you think of some examples that would become part of the basic expectation that the patient has?
Attending to the patient as soon as she comes to me.
Okay.
The teacher, the staff taking the basic vitals.
Absolutely.
Yes.
But we need a patient, clean sheet, bed. That's expectation. It's a very basic expectation. So they are not going to come and thank me that thank you. Your bed is very comfortable or the sheet is very clean. But that is what they will expect. Am I right?
Yes.
So some of the expectations that we think are the examples of, basic expectation: availability of the staff, prompt attention, you have already mentioned, reasonable waiting time. These are all very, very regular expectation, basic expectation. So they are not going to come and thank us for this. The second set of expectation that the patient would have, we call them as satisfier or performer. And trust me, if you are able to look after these expectations, most of your patients are going to go back very, very happy. So these are the expectations patient would have. If they are met, they are satisfied. Patients are going to be happy. When they are not met, of course, they are going to be dissatisfied. Some examples you can think of. Can you think of some examples?
Conveying regarding their illness.
Okay. So when you explain to your patient about what it is and what it looks like and so they will think, oh, very nice, doctor explained me everything in a very meticulous manner. So that's something that they expect. But a lot of time when we don't do it, they're unhappy. But when you do it, they are happy. They're more than happy. Anything else?
They might have come
waiting in the outpatient section for a long time to be the doctor.
So will that be a performer? When I say performer, that means these expectations you are proactively meeting. You have identified these needs and you are already fulfilling these needs.
Taking their consent before examining them.
Even when we know that we talk of implied consent, But in knowing, because implied consent, we know, patients do not know. But when we ask them, I need to examine you. Are you comfortable with that? I need to check your back. Are you okay with that? So you are kind of taking a verbal consent. So again, they're happy, they're very well behaved doctors. Any other example?
Being an active listener, giving them ear for enough time.
Okay, if you are allowing them to speak and you are listening them and noting down important points, they're very happy. Your doctor really attended to me. How about when the
Consultation fees is less.
patient...
Consultation fee is less.
Yes, they are happy, definitely. Reasonable consultation fee. They are happy. Your doctor is very nice and charges very reasonable. Absolutely, I agree. A lot of time we charge very exorbitant and then we don't give them value for money. They are very unhappy. Both are true. I would agree with you. So, for example, if I talk about some of the satisfiers, you will see when you have a very courteous and well-behaved staff in your team, patients will go and appreciate. Very nice clinic. Staff is very nice. They're very well-behaved. When the waiting time is minimal, for example, you have given them an appointment and within 10 to 15 minutes, if they're seen, they're happy. I've seen a lot of patients, especially in private setup, I've seen, they will have the patients wait for almost like 1, 2 or 3 hours. There was a mindset, if you have a large OPD and if there is lot of people waiting, it sends a message outside, oh, he has a huge practice. Lot of patients are waiting outside. But trust me, today patients are not happy with this kind of a mindset. If you make them wait, they will not come back to you. They'll say, I'll better go to another, doctor. Or doctors welcoming behavior. If the moment you start interacting and if your behavior is good, patients feel that, oh, doctor is very nice. Doctor attending to the patient with full attention. This you have already mentioned, when the doctor listens attentively and pays attention. Then allowing the patient to narrate their problem. That's one thing patients really want to, have full enjoyment of. And then allowing the patient to ask questions and answering. So when we say, do you have any questions? Instead of that, when you say in the end, what questions do you have about your, treatment? So I'm sure they'll come up with 1 or 2 questions. And then when you answer those questions with patients, they're all yours. Okay. The third, patient's expectation category is called delighters. So delighters are, that's the need of the patient, but usually patients would not expect us to fulfill. But when they are met, they are very, very happy. So these are like unexpected requirement turned into a pleasant surprise. Can you give an example of this delighter?
Patient is suppose coming with a mass in the breast and they're thinking that it is going to be a cancer, and when you examine and found that it is a benign lesion, very curable, she'll be so happy.
Absolutely, I think that's a good example. Any other example of delighters?
Patient,
Answering the
admits-
answering the WhatsApps promptly and
Oh, yes.
yeah.
When you answer the, I know some of the doctors did not like to give their phone number to the patients. But I have seen, I'm not talking about the government setup because the reasons are different. But in a private setup, when you give your phone number and when you tell them that please don't call but message me, I'll definitely respond. Trust me, the practice goes many, many folds. Yeah, Dr. Paul, you were saying something in between.
It is about the final bill of the patient. No? When you reduce it and give, that is what they don't expect actually. Instead of them asking you to reduce the bill, see, initially there are counseling for the patient, not the counseling. Like they will come for an operation, they will come, what is the expectation and how much, this much money is coming. Then finally, if the bill is less than that, that is a delight.
What was the last point? I missed it.
If their expectation, expectation of the bill, which had already been spoken to the patient, if it is lesser, then the final bill comes. That's always a delight.
Lesser than what they have been
What they expect.
informed earlier.
But I doubt if that ever happens.
It happens.
You can always give a big bill and then bring it down. like the merchant does it by
Yes,
giving.
discount.
No, they do window shopping. They definitely
I
go to
think
the
I
other
think I
hospital
shared.
even if it is
Did I
lesser
share
amount.
this with you? My father was, admitted. I think I shared with all of you. Or no, I don't remember. Uh, my father was admitted in a heart for cardiac surgery, for bypass surgery, in for a package. And then I was little away from the hospital for some work. I received a call that your father, we need to ship your father to the side room because actually it was more like ICU psychosis. So he was like, acting aggressive and so they put him on medicine and then they moved him to uh, side room. They called me to say that we need to move your father to the side room. I said, it's okay, it's your call. You have to decide how you want to manage the case. And then I received second call that your package will be different now. They had already operated. It was second or third post-operative day. Because the patient is moved from ICU to side room, my whole package will go. Will it be a delighter for me?
That will never happen.
So you charge me for this side room. I'm okay to pay for that. If you say that it's not right to keep him in the ICU and we are moving into side room and you'll have to pay for this side room, okay, whatever the difference is, I'm ready to pay. Honestly, this is the state of affairs. Let's be honest. Let's be honest. Yes, Dr. Asha, you have a point to make. Please go.
Another delighter would be a heavy OPD after waiting for long without coming without an appointment, but seeing the doctor gives the option for, do you have any questions, and answering patiently to their questions. They'll be delighted.
Absolutely. Absolutely. So you're canceling your patient's appointment for some reason and you inform the patient that please do not come because we need to reschedule your appointment. The doctor is not available. Do you think they'll be delighted? So we have seen a lot of hospitals now, doing the cake cutting for the patient or the family member because it's their birthday and they have noted down and they want to surprise the patient. Of course, these are different ways people are doing. Then also for the newborn, they arrange photographer for the newborn. I mean, there's always a business behind all this. But then in genuine sense, if you can create some delighters, they will be happy. Yes, Dr. Lata, I think you wish to say something. Please.
Yeah, it's discharging. When always there's a delay. Once we say that you're fit for discharge, and it goes on till 4 o'clock. And also, if we know an exact time, like it's going to be around 2 o'clock, and if we tell them by 3 o'clock, definitely it will be ready. So if they get it 1 hour early, it's definitely a delighter for them.
I think discharge is one of the biggest reason for the conflict at the last minute. The moment consultant says discharge, patient thinks, I will get my papers right away and I can go within 1 hour. And usually it takes almost 4-5 hours, especially to get clearance for the TPA, get signs from different departments, clearing the bill and a lot of other things. Why not inform the patient? I'm writing discharge, but the whole process takes around 3 to 4 hours. We cannot discharge you till we get the clearance from TPA. So you will have to bear with us. And then you will clear it. But thank you for telling this. If you can discharge earlier than that, you say. So when we give gifts like small toys or chocolates to children, yes, that also comes as a delight. Yes, I agree with you, Dr. Deepa. So when you are informing the patient about the rescheduled appointment, it's a delighter. So telephonic follow by the hospital staff, it was your appointment, you haven't come. Or sometimes post-operatively, post-procedure, they are supposed to come for follow. If they don't come, and if your hospital staff follows up, they feel good about it. Like one of you have already mentioned, doctor willing to ask and address their unspoken concerns. They feel very good. The doctor really paid attention and asked me if you have any concerns. And
Personal details.
Yes, doctor remembering the personal details of the patient. If you know about something, oh, that's your son, that's very nice. Just 1 second, give me a second.
One tip for the personal details, I think in the phone, when you save the number, you can write a few details about the patient. So the moment he calls, you
Yeah.
give him the whole history, he's so happy.
Yeah. Someone used to put some signs or draw some diagrams and yeah. And next time, oh, the doctor remember
I do that.
everything.
I do that on my card always. So that if they come with the card, we can ask them that. They do not come with the old report. We are
Oh, last time you remembered, this time you are not remembering.
Exactly.
So, what are the consequences of unaddressed expectations?
Unaddressed.
So, if you don't address their expectations,
Dissatisfaction,
conflict,
dissatisfaction,
Violence.
Agitated patients.
unhappy patient,
unhappy patients, absolutely.
You'll lose the patient and will get negative
Absolutely.
impact also.
Absolutely. People
I
will
lose the patient.
Not only that patient, but maybe other patients also.
They don't mind writing wrong, poor reviews for us
Yeah.
in the dissatisfied. Absolutely. So you have covered almost all the points. If they are dissatisfied, there's a chance of conflict, reduced footfall. They may write bad reviews. They may create bad reputation for us. Of course, risk of violence and aggressive reaction. We can't, ignore the risk of litigation. We have seen. I think I did share with you one case where so this lady, she had delivered in one of the gynec clinic. That doctor is a friend of mine. So it was a normal delivery. Everything went well. The lady got discharged. After 2 days, she kind of came back for follow up. In those days, like I'm talking about good, almost like 10, 12 years ago. So she had episiotomy. She came for a follow up. The doctor who was who was seeing her, she said, "Sister, iski dressing kar do." So the husband of this patient who was sitting, in the same room. He said, "Doctor, why don't you do it?" And the doctor said, "It is a nurse's job. It's not my job. She will do it." So the nurse did the cleaning and then she put the bedded and everything. They went away. This person was a small-time journalist. He got so frustrated with this whole thing that he went on writing complaint against this doctor in all the departments. Then let it be electricity, water, biomedical waste, building department, everywhere. And she had to literally, she wasted almost 5 years in getting everything clear. And the amount of money she spent on clearing all this, I can't, the mental trauma that she must have undergone. So a lot of time, we have to be very careful when we are involving, because you never know, sometimes these people can create such kind of problems also for us. And then, of course, all this would lead to reduced professional satisfaction among your team members also. So if I may just talk about what really brings about patient satisfaction, out of it, almost five or around communication. Communication with nurses, communication with doctor, communication about medicine, responsiveness of hospital. So I think we have to understand patients expect this from us, and we really need to that. Of course, rest is also very relevant, pain management or responding to their immediate problem. Cleanliness, discharge instruction, like one of you said, that if you clearly tell them what time and what instructions are, and then overall rating. So here I want to introduce you to a beautiful concept, and that's concept of design thinking. How many of you have heard about concept of design thinking? Has anyone heard about concept of design thinking? Raise your hand if you have done. You can write in the chat box. Yes, I have an idea. Nobody? Okay. So design thinking is a concept which is used by lot of multinational companies, where they are trying to look at the service or the provision from the user point. So it's not that what I want to offer, what my user wants, what my customer wants. That's the idea they are working on, and that's the reason how they have been able to successfully create a business model. So this whole idea of design thinking, I want to introduce you because this is one thing that you can use in your setup and make best use of this concept. So it has 5 steps. So design thinking is a concept when you look at the whole delivery system from the patient's need and requirement point of view. So the first thing that you need to do is empathize. So that means you have to really develop a deep understanding of the challenge that the customer or the user or the consumer would come across. So you have to really go in depth about what do my patient or consumer or customer feel, need, think, require. I'm going to do a small activity to help you empathize. All of you have a copy and a pen? All of you have a copy and pen. If you don't have, please get it. Okay. So I'm going to take you to a journey, and I want you to note down whatever I ask you to note down. So imagine that you are, entering your hospital for consultation, and you are not a doctor.
You're,
Pardon.
sorry?
You're going to your hospital for a consultation, but you are not a doctor.
Okay.
You don't know anybody, and nobody knows you. Okay? That's the background. Now, you're one second. Okay. So now, imagine that you are, entering your hospital gate as a patient for an appointment with your doctor. See yourself parking your car. You have entered the parking area. Since you are not a hospital employee, the parking person does not know you. So what expectations do you have from the parking fellow? You can just note down, is your expectation fulfilled by the parking fellow? Look at the parking area. Are you okay with the way that area is maintained or looked after? You can write down your expectations, met or unmet. Conduct of the parking person and also the parking area. How does it look? How does it feel to be there? After you have parked your car, you have now entered the hospital building. See yourself at the reception to confirm your appointment and your availability of your doctor. You're standing in front of the front desk staff. You can see the conduct of your front desk staff with whom you are confirming, is my doctor available? This is the appointment that I have. Now, the receptionist says that it will take you at least 45 minutes. Then you check, how long will I have to wait? And your receptionist says it will take at least 45 minutes to 1 hour. There are 6 to 8 patients before you. And you are requested to go and wait in the waiting area. Now, again, check your expectations from the receptionist in terms of the quality of interaction. Were those expectations met? Since you know your hospital, you know your staff, I'm sure you can guess how good are they interacting with the patients and answering their questions. Look at the physical setup of the reception and the registration counter. Are you satisfied? Do you think that is user friendly? You have entered the waiting area, which is just, very close to the reception. Look at the waiting area. Look for a place to sit. Are you happy with the area? Are there enough seats? Is there a place for you to sit? How do seats look? Neat, clean, comfortable. Also, look at the other arrangements, like water facility,
Toilet.
cleanliness, ambience of the place. Are you satisfied? Is that need met? Are you okay with the waiting time? You can note down. Listen. Now your turn has come to meet your doctor for the consultation. Since you are not a doctor does not know you. You enter his or her chamber. Look at the conduct of the doctor. Look at the quality of interaction. Are you satisfied? Are your concerns addressed? Did your doctor listen to you, treat you with respect and dignity? Are you satisfied with your interaction with your doctor? So you have been asked for some blood work. See yourself at the lab. Try to see the overall lab appearance or ambience, behavior of your lab technician, the way he talks to you, explains you, answers your questions. After the lab, you go to pharmacy to collect medicines that your doctor has prescribed. Again, try to focus on the expectations you have from your person who is dispensing the medicine. Why you explained well, why you treated well, why you asked, are you okay, are you clear with the instructions? Again, why your expectations met. So before you go back to the car parking, you feel the need to use the restroom. Imagine yourself entering the patient's toilet. Look at the cleanliness, hygiene, smell, overall keeping of the restroom. Check your feelings after using the restroom. Get into your car to return home. Are you satisfied with your visit? And if I ask you to rate your experience out of 10, what would you rate it? You can put the rating in the chat box. Oh my goodness. Write your rating in the chat box. I think this gives us fair idea about what your patients must be experiencing, isn't it? So friends, I introduced you to the idea of design thinking, where the first step is to empathize, where you develop a deep understanding of the challenges your patients must be experiencing, or whatever their expectations are, they fulfilled on. After that, you sit and define what areas you want to focus on. So you have listed down the problem. Now you have defined what you're going to work on. It could be ambience, it could be conduct, it could be cleanliness, it could be patient safety, whatever you think you need to really focus your attention to. And then the third step is ideate. In ideate, we actually work and brainstorm and see what solutions are possible. So usually if it is one person who just tries to create ideas, it may not work. But when you have more people on board and when you ask them to create ideas, usually you are able to come out with lot of ideas which may not even appear doable in the beginning. But when you brainstorm around it, you are able to find something that is workable. So for this, I normally give a tool called CREATE. You can note down if you want. That's a acronym again. CREATE, CREATE, CREATE. So when you do this activity of ideate, you use this tool called CREATE. So it's an acronym. CR is current reality. Current reality. EA is explore alternative. So you have defined the problem, that is your current reality. When you are creating ideas, that is EA, that is explore alternatives. So what all can be done to find the way out from this. So EA has two steps. One is mining and second is shining. Mining and shining. Am I audible?
Yes.
Okay. So mining is when you just try to dig out as many ideas as possible. I mean, there's no limit. There is nothing called logical or illogical. Let people come out with whatever you think is doable, is possible. Once you have digged out all the ideas, then you do the shining. And what is that shining? Pick up each idea and do SWOT analysis on that idea. Strengths, weaknesses, opportunities, threats. So when you do this mining and shining is when you have picked up each idea. So maybe initially you had 8 possible ways to deal with that. Then you come down with 2 to 3. So the last TE, create. T is tap energy. So tap energy is where you actually create a prototype. How are you going to implement this? How are you going to work on it? So once you have a prototype ready, then you need to test it before you can actually implement in all departments. So for example, if you decide to reduce waiting time, so maybe you will pick up out of all the solutions, you pick up one, methodology to reduce waiting time, and then you will implement in one department initially. Okay, we'll do this, this is how we will handle, this is how we'll reduce the waiting time. And that is called testing. Once you see that this is working, doable, then you apply in all other areas. So initially you will implement in a smaller area, in one area, and you will test it. So these are the 5 steps under design thinking. Design thinking as a concept is being taught even in universities like Stanford and Harvard, because this is considered a very meaningful tool in creating services that are, created keeping in mind the user in the center. And I think it is time that we start looking at healthcare delivery system. What we are talking about patient-centered care, it's all about nothing but design thinking. So I'm sure you must have seen, something like where they have created MRI department or MRI unit or a pediatric department where they have created ambience for children, which makes them comfortable and which reduces their anxiety. I'm sure you must have seen some of the OPDs or the waiting areas where they have created a lounge like 5-star, where they think that people who have to wait for hours, they should be comfortable. At least that part can be looked after. So this is another hospital OPD where they have tried to create a waiting area to make the patients and the families comfortable. So they are all the concepts of design thinking being implemented in the healthcare sector. I think it is time we understand patients' expectations and meet them. This is briefly about patients' expectations and also design thinking as a tool. So I would, ask you to apply this concept to your hospital, any one department, and try to, improve your services and function. So to sum up, I think the common expectations of the patients are compassionate care, effective treatment, clear communication, respectful treatment, accessible and timely care, respecting their privacy, cost-effective care, and then high quality. And I think this is something all of us would expect if we were in the patient's place. Am I right? Okay. Any questions about this concept? Dr. Paul says infrastructure and manpower is there, everything is possible. So, Dr. Paul, for a successful practice, there are 3 factors I normally say. It is ABC. And what I say, ambience, behavior, and clinical acumen. All 3 are very important. But what I have seen, or what my understanding says, what studies also suggest, see, if you have good ambience and if you have good clinical acumen, patient will be happy that yes. But if the behavior of the staff and overall team is not good, ultimately they will look for a person who has a better behavior. Even when you say patients go window shopping, one of the reasons when the patients decide to hook with the doctor is when they are satisfied with the behavior of the doctor and the staff. So I would say, even if you have average ambience and average clinical acumen, trust me, if you and your staff's behavior is good, patient will still come to you, because they look for somebody who can understand and address them. Most of the patients, they don't have very high expectations, because if they're coming from a very high-end kind of a background, of course, then they will expect something. Then they will go to a setup. They will not come to an ordinary hospital. They'll go to 7-star hospital. I have seen some of them also. So that's a very different ball game. But then generally, most of the patients, if I say 70-80% patients, their expectations are very basic. But are we even meeting the basic? That's the question. Any questions? Any point that you wish to add? Thank you, Dr. Paul, for bringing that up. Thank you. That was a good.
The first, the case you asked us to study, if you take it in a different way, that Dr. Raghavan, in the present setup, he will be the only doctor in the emergency department. Okay.
Sorry, I didn't get the last line. In the present?
I'm not audible.
Slightly, I missed. I'm sorry.
The first case today.
Yeah.
Today's first case, talk about Dr. Raghavan. He will be the only person in the department if you take the current scenario. If there are enough doctors there and enough staff with him, he has done correctly. He has seen the patient, he has diagnosed the thing, and he has found out that it is harmless. So if there was enough staff, adequate staff, and he has assistants, they will deal with the patient. So the condition is not like that in the present hospitals. There will be only one ED doctor during night time.
So, Dr. Paul, I completely understand what you are saying. At the same time, I want to say, how much time will it take to even communicate this much to the family that it's nothing very serious. Don't worry. ECG is okay, but we are going to do some more tests. We'll be observing your thing. I don't think it will take more than 2 to 3 minutes.
If he's examining less than 10 patients, that will definitely happen.
So I can give you examples of doctors. I remember in one of the program, one participant shared his experience. He said, I took my father-in-law. He himself is a doctor. He took his father-in-law to a cardiologist, very renowned cardiologist. He said 1500 was his consultation. I'm talking about good 5-8 years ago when he talked about it. And he said that very with great difficulty, I got my got appointment, an earlier appointment, saying that I'm a doctor and I want to show my father-in-law. He said he went to him, and this cardiologist, took away all the papers that he had in his file. He just looked at it quietly, and then he immediately wrote some tests to be done. He did not communicate with the patient. He did not communicate with the doctor. He said he just did not speak to me even a single word. Then second visit, I went again after getting all the investigation done. He saw the reports and he wrote the medicine and he sent the patient back. He said, again, I paid the fee. I took appointment. He did not pay me. He did not talk to me. See, you will have a lot of examples from what you are saying. The learning that we can have is that it is not how much you communicate, it is how you communicate. When we talk about escalator pitch, you may have 10 things to talk, but if you think 2 things are essential, you will definitely talk about. I'm not saying spend 10 minutes chatting and have a cup of tea and talk to your patient when 110 patients are waiting outside. But these few lines telling to your patient that everything is all right, don't worry, we are doing, and we are going to observe you. They won't take more than 2 to 3 minutes. That is the sensibility I'm looking for. I ask, this is the same question I'm asked by my interns. Where is the time to build rapport? Where is the time to talk? I said, do you go to collect patient sample? They say, yes, we go to collect, because interns have normally either to do the patient sample collection or discharge me. I said, how many times do you make eye contact with your patient? How many times do you say, hello, sir, how are you feeling today? How many times do you even ask the name of the patient? How many times do you smile at your patient? Is there something extra that you are expected to do? No. But mindset is that I am going to do it mechanically. So we can give 100 example, 10 example to argue on this. Idea is not to argue on this. The idea is to teach our doctors that, see, it is not how much time you spend. It is the quality of interaction. If you make an effort to build rapport, you don't require extra time, but your patient can sense that you are a good doctor. That is the impression I'm talking about. And wherever you think the patient family is, fragile, or there are red flags, handle them promptly. Please handle them promptly. We are focusing on how do you prevent violence against us. We are focusing on how do you improve our relationship with patients. And honestly, see, all said and done, I'm for all of you. If everybody is against me, then I have to sit and introspect. If everybody is against me, then I need to sit, where am I going wrong? Where am I not working on myself? I can give 110 excuses, but when I am in a situation, I'm all alone. And if my patient assaults me, I'm the one who's going to be killed or, face violence. So I have to prepare myself and my doctors to see that we don't get to see this. And if these small things can help us prevent violence, I would say go. And honestly, if you are going to talk to your doctors as trainers, first you have to be thoroughly convinced with the idea. Please communicate. Communication can prevent violence. Communication can satisfy your patient. Communication can prevent a lot of unnecessary conflicts. And we all know that. But if you are not convinced with the idea, then probably the questions that you are asking me, your doctors are going to ask you, and then you will be speechless. You will say, yeah, I agree. Because there is no infrastructure, there is no staff. That is why there is violence. We have so many places where there is enough, but still people don't talk. How will you explain that to me?
When we enter a hospital, don't say that you are a doctor. As soon as we park the car, that security fellow will not open a word. As soon as we step out, he'll say, don't park it here. There starts the irritation. Till you park, he will be just watching you for there. And then finally, when you get out of the car, he'll tell that don't park. When I tell my colleagues that go to a hospital, not in your town, to another hospital, and different, because in your town people will know you. Go to another hospital, you go to the reception and see how the staff behaves. They behave very badly. Because I go to many hospitals, I don't disclose myself as a doctor, and then I see the
Mystery customer. You go as a mystery customer.
and then later I tell them, see, I'm a doctor. Then there will be a sea change in their behavior.
Absolutely. Absolutely. So it's a choice we make, honestly. It's a choice. I can talk about 110 deficiencies in the system, or I can choose to work on my behavior and conduct so that at least I am safe, my team is safe, my department is safe. Okay, it's already 10 past 10 and we have 3 presentations to go. That's why it's at only 8 minutes. Can we have the presentations if everybody is okay? Quickly, as short as possible. So we'll be presenting first. Dr. Harimon, okay. So I am allowing you to share your screen, and then Dr. Lata, and then Dr. Sonia, will you be presenting? Okay. So I have allowed you to share your screen. Dr. Harimon, you can please. Floor is all yours.
I don't get the share. Okay, 1 second. Yeah. Oh. Yes. Yeah, I hope you can see it.
Yes, we can see it. Thank you.
Oh. Okay. I'm going to talk about role play. Can you hear me clearly, please? Okay. The definition of a role play is in the health sector is a simulation of patient and family. Either as a person, we take up a role play of a person or a situation, either two or a group, and interaction by the healthcare provider. Now, the step 1 is identify what the situation is, add the details of the situation, assign the roles, and act out the scenario, and discuss what you have learned. Like, for example, if you are having a patient, a doctor, and a bystander, what happens, that is the situation, add the further details, and we can have an aggressive bystander, a very calm patient, assign the roles, act out the scenario, and then discuss what you have learned. Now, it imparts a lot of interpersonal skills, communication skills, conflict resolutions, developing insights and group decision making because of what we go through and what we come across. There's something called a Shakespearean spins, Shakespearean plays. They assign roles. This could be called as a spin-off like that, role play. Now, young medical students, when they're asked about a role play, they're not very happy with it. There are a lot of apprehensions for it. There's a lot of resistance and anxiety. They don't take it seriously. Some of them have previous experiences of embarrassment. They're not happy to enact interdependence in learning. Almost 75% of medical students believe it's as not a very effective pedagogy. It's actually an ineffective teaching method according to them. Why? Because it's unreal. The emotions are not real. It's put up. Overreaction is possible. You're functioning under observation by somebody. You can't relate to the experiences detected. And post role play, most of them say 70 to 100% agree it was quite useful. The types, either it is fully scripted, partially scripted, or extempore. We just enact what you like. One person is giving instruction, the rest have to react. And then we also switch the roles so that you can get to be a doctor or a patient or whatever you want to be. There are 4 learning environments here. One is affectively oriented is the feeling, symbolically oriented is the thinking, Perceptually oriented is the watching, and behaviorally oriented is the doing. And the readiness to learn and feedback is vital in such role plays. And there are three principal participants: the interviewer, patient, and the observer. So when we go into the steps of a role play, I'm sorry, I'm just hurrying it up. I don't want to go into details. It's obvious from the slide. One is warming up before it starts, the selecting of the participants, the observers, the enactments, and then very important is to discuss and evaluate. And then the reenact again, rediscuss and evaluate and generalize. Thank you.
Thank you. You really made it very, very brief. So can you stop sharing so that we can quickly have?
How do I do that? Oh, stop share. Okay. Yeah.
Thank you. Thank you. So any questions from the audience?
Sorry, I was very hurried up. I didn't explain the slides, but since three people have to do it, I thought I should.
But I think role play is one way you will find very useful and engaging when you will do training sessions for your audience. Initially, there will be hesitation. So there are many ways actually you can go, but one is you can give them a demo, how to do it. And then you could ask them to practice, and then they would, give you, they will show you a role play. Second could be you can ask them to do the role play, you give them a situation, ask them to play the role of a doctor and a patient or a family member. And then you will see naturally if they have not learned the steps, they may make a lot of mistakes. And then you can have a discussion around it. And then you can, give them a return demo by you doing the same role play. Important is when you give feedback over the role play, please remember, restrict the number of faults that you are going to find in the role play. What happens during role play? Mostly we look at the mistakes that the person has done as a player. The thumb rule is 3:1. So that means 3 good points and then 1 feedback that you can give about what could have been done differently. You have to be soft, you have to be positive. The idea is to encourage people to role play. For example, if you did a role play, somebody did a role play, and as a facilitator, if you were very, really critical about the role play and you found 10 faults in the role play done, next role play, nobody will be ready to take the chance. So you have to be you have to go soft. The idea is to promote participation. The idea is to encourage people to participate. It's very unrealistic. It is very difficult to actually role play for a patient or a family member. Of course, in Western countries, they have standardized patients, they have simulated patients, where they have actually people like you and me who have been trained. Even country like Sri Lanka, I mean, when I went there for a training program as a facilitator, they had a good, number of people who were already trained to be patients. And the acting they were doing was so natural that it appeared that they are actually experiencing the emotion. Yeah. Unfortunately, in our country, we are still at a very, very preliminary phase. I don't think we have even, any number of people who
are. We had an extensive role play during my fellowship. We had hours of that.
Yeah.
So, in fact, many of our mistakes in the communication was pointed out because of that also.
Yeah, very true. So using this as a tool would be a great help because it leads to experiential learning. People really get involved, they get engaged. They may not admit at that moment, but there's a lot of food for thought that they can churn at the end later on. And then they'll come up with this, yes, I learned this from this room. So use this extensively when you do training programs. And plus your job becomes easy because then your job is just to, facilitate. The rest of the learning happens through their participation. And we'll be doing role plays from the next session. So you will see how much of learning it really brings about when you do it.
Just one question.
Yes, please. Go ahead. Yeah.
See, when we are asked to present, I'm just talking about the presentation, pedagogy, about the role play.
Yeah.
Can you add a role play in the beginning and show?
Ideally, it should have been, we could have taken one small situation. But the thing is, I'm just giving 7 to 8 minutes per presenter. So therefore, I did not insist on doing a practice session. Second thing is because from next session onwards, there will be a role play in every session. There will be a role play. So we will be participating as a difficult audience, or sorry, difficult participant, or uncooperative patient, or coming with a complaint, or breaking bad news, or disclosing medical errors. So these are all difficult communications that you will have, and some of you will become patients, and some of you will become doctors who would be doing the. So we all will get a chance to. Yeah. So you will experience it from the next session. Therefore, I did not insist him to do the role play, to show us what role play is. So thank you so much, Dr. Harimohan. I think it was a good presentation. You briefly, talked about everything that was related to role play. And please remember, engage observers. Engage observers.
Engage
Observers. Give them a very specific task. Okay,
task.
you observe their body language, you observe the language part, you observe the tone of the voice, you observe the overall body language. So when you assign everybody some task, everybody will be keenly observing and noting down. And then you also ask them to, note down their observation, and at the end, you can ask them to talk about what they did effectively. As I said, talk more of what was done well rather than finding fault with the role.
That is among students only, we will have to engage observers.
See, if it is for example, if your audience is students, then of course you will be taking students. But suppose you are doing it for residents or nurses, then you will have to take them as the, players of the role play.
Not the players. Observe the observation of the. You said that you have to observe the.
There will be audience. So, for example, you are 15 of you now, for example. So maybe three of you will be doing the role play. Rest 12 of you will be observing. So you will be observers. Yeah. You will be observers. Any other questions related to role play? Okay. So can we have the next presentation?
Madam, I'm not able to share my screen. I'll just go through my mobile. So if the other presenter can do it now.
I think you have logged in from 2 devices and there's a lot of echo. So it would be good if you log out of the one. Yes, I can request Dr. Sonia to do her presentation if that's okay with Dr. Sonia. But please log
Yes, madam.
Yeah, because there's a lot
Can
of
I
echo.
share the screen?
I have given you the rights. Yeah, you can. Yeah.
Visible, ma'am?
Yes, it is visible.
Yeah, after madam's passionate presentation, it's very difficult to go ahead with a presentation, that too at 10:20. What I'm supposed to present is experience sharing as a way of advantages of experience sharing as a way of enhancing participation. So as madam said that to get everybody's involvement is the whole idea. So active participation and knowledge sharing are crucial in various contexts due to their significant impact on learning. And they enhance engagement, encourage diverse perspectives, and promote a sense of ownership and empowerment. Otherwise, the one is just speaking something and others are not involved. So they enable the individuals to learn from each other, tackle complex challenges collectively, and build strong connections with the community. For example, as a community, we share very strong connections. Even we have not completed the program because we share our experiences and thoughts. So active participation and knowledge sharing foster a dynamic and engaging learning environment. When individuals actively participate in discussions, share their experiences, share their perspectives, they become more invested in the learning process. This level of engagement promotes deeper understanding, retention of information. Retention of information is very important. Otherwise, somebody goes on speaking, we hardly retain 10% of what is spoken. And critical thinking skills. It also encourages collaboration, peer learning, and enhances experiences, insights, and expertise. We can learn from each other's experiences. We know that when there was no Google, the seniors were our ready reckoners and encyclopedias. We used to share their experiences in everything, whether it was what to study and how to deal with a particular teacher, etc. So that's also part of experience sharing. Now, when it comes to problem solving, individuals can bring diverse perspectives, ideas, and solutions to the table. So it brings in collective intelligence. Each participant's unique experiences and knowledge contribute to a more comprehensive understanding of the problem and potential solutions. Active participation also fosters brainstorming, innovation, and exploration of different approaches. Like Madam said, in the design thinking, we can have brainstorming so that very innovative ideas come in from very unlikely people. So now about community building, as we said that when individuals actively participate in community activities, they share their experience, they share their expertise, especially we can see that in the surgical forums. When they share a particular complication, the others also become wiser. And there's a less effort involved when somebody shares the already experienced thing. So they create a sense of ownership and belonging, and knowledge sharing with community promotes mutual learning, skill development, and improvement. Now, this builds trust, and inclusivity is the key word. It includes everyone in the whole process of communication. Like Indu ma'am does with us, inclusivity is very important. Now, practical insights are gained with less effort. As I said, that we may not have experienced it, but somebody who has already experienced it, he shares the practical insights. And there is contextual understanding that happens, accelerated learning, and more networking. Like we are already into a loop and a networking if we take our own example. And it's definitely inspiring and motivational. But there are certain disadvantages in the form of it can limit the range of viewpoints and perspectives. And we know there are 100 people, there are 100 biases, there is subjectivity, there is personal agenda which creeps into an experience sharing. Not all shared experiences are accurate or based on reliable information. So without proper validation mechanisms, there is a risk of misinformation. So what are these validation mechanisms? Like that can be an academic research, established best practices, or presented papers, expert opinions, etc. So there is a significant resource. We know that if I want to make you share an experience, it's really going to take time, effort, and coordination on the part of the facilitator. So probably, I think at 10:25, I may not be able to, I may not be expected to do that. And unequal participation. In our own group, we can see that some people are listeners, better listeners. Some people, they voluntarily participate, some don't. So these are a few disadvantages of experience sharing. It's a very simple thing that we do. We always share our experiences and the anecdotes while we talk. That's the easiest part. I think it's easier done than the role play. So thank you. This is the concluding statement that active participation and knowledge learning is what it does. A lot of brainstorming, collective involvement, and there is a collective intelligence that goes into this pedagogy. By doing so, the potential drawbacks of experience sharing can be minimized. We can also involve people who are experts in the field, and this can minimize the drawbacks of experience sharing. Thank you very much.
Thank you, Dr. Sonia. Thank you. Could you please stop sharing that? Thank you. So quite detailed, presentation with a lot of content to reflect on. So just to briefly, talk about experience sharing, there are two ways. One, you share your experience, and second, you make your participants share their experience. Both are doable. Both are okay. When you share your experience, it creates curiosity because people do not know what you have experienced or what you're going to share. So automatically your audience will become attentive. Experience sharing can be used at the beginning of the session. It can be in between, or it can be towards the end of the session, wherever you want to use it. But when you make your participants speak and talk about their experience, you are able to engage them. And that, especially with adult pedagogy, as you were asking me in the beginning. So with the adult audience, how is it different? I think that is one tool that really helps to connect them. Role play, still they may not open up easily, especially for the initial session. But experience sharing, if you have the right questions, they will be able to share their experience. They'll be happy to share their experience. Most of us have a lot of experience to share. But you have to have a right context and right questions to ask. Thank you so much. I think it was a very elaborate, very detailed presentation, Dr. Sonia. Thank you for making all the effort. For future sessions, I would suggest try to make your presentation interesting. That's what I'm looking for. More than content, create experiences. I think if you remember when I talked about designing a program, see how you can make it interesting and engaging. Have least content, very minimal content on the presentation, on this slide. And even if you want to talk, that should not be there on this slide, because your audience can do only one thing at a time, either see or hear. CPU is common. Please remember. The processing unit cannot, engage with two senses. So either I can see or I can hear. I would say have minimum content which can be read, but I can focus on listening to you. So try to work on your presentation. I know it's something new we are experimenting with. People normally say online programs are not successful. Somehow, in the last, this 1.5 or 2 years or 3 years, I have worked on making it engaging, and I think this should be an example for all of you how you can go ahead and make your program engaging. Have activities, have some, flavor added to your session. This is what I'm looking for. That's the whole idea. Have minimum content. I think one of you is going to present on how to make effective PPT. So we'll all learn from you how to really, make your PPT interesting and enjoyable. So it's all right. We are all learning. We are all doing. It's perfectly all right. I'm sure by the time we'll complete this session, we'll have more experience to share with each other. So can we have the third presentation?
Yes, ma'am. Lata, ma'am, screen sharing.
I have,
yeah.
You can share if you want.
No, but I'm not getting it, ma'am, now. I have actually changed my, I've logged from another.
Should I add you once again?
Yes, ma'am. Yes, ma'am.
Okay. Try if you can share now. Are you able to do it?
Answer.
What is the issue you are facing?
I'm not able to, it's coming as an unsupported document.
It's like it is opening in a PowerPoint in your computer.
Yeah, now, yes.
It's opening in your computer. And it is on the screen. You open it and keep, and then just share the screen.
You click on share screen.
Open the document and keep.
Okay.
Open the document, then share screen, then you will find that on the screen. There will be a share.
Okay.
Click on the share, and then your desktop will open up.
Okay, so I'm just trying it.
click on share screen. There's a share screen, green color.
Yeah, the thing is,
Now we could see something.
So, Dr. Lata, is that the same presentation that you have shared with me? Or you have made changes?
I think she is not there.
Or rather, some other person can share it.
That's what I was
Ma'am,
saying.
If
Oh,
ma'am is having that, ma'am can share.
maybe if she has modified, then I need to check with her. I think she will rejoin. She will rejoin. Let me check the. I have a copy of it, but I don't know if she has modified and resent.
She is not online now.
Yeah. I can't see her. I think I have her thing. Let me meanwhile see if I can find her. So can someone call her and ask her to log in, and I will share the screen. Let her not be. Can someone call her? Ask her to join, and I will share the screen for her.
Hello, log out ആയി എല്ലാത്തും ഒന്ന് റീജോയിൻ ചെയ്യും. Yes, told her.
By the time she comes in, let me thank all of you who have written the book review. I have seen a lot of good, words written by many of you. Thank you so much for taking out time and writing the review. Thank you.
And can I make a request?
Sure.
We're having a leadership program on Sunday
Uh-huh.
at Alway. It is the IMA house at Alway. So can I put the flyer in this group so that I can invite all the others?
Absolutely, no problem. Absolutely.
Yeah.
You can put even in the WhatsApp group if you want.
Yes, in the WhatsApp group. That's what I was
Anything
just.
that is for the professional development, I think it should be encouraged.
It's a WD.
It's okay. We allow men also in. We are very encompassing. So we allow you also.
We didn't see this in our group.
Yeah, that's why I said. That's why I said I didn't put it in the IMA. So I just thought I'll put it in this group. I've sent it to all the leaders. I didn't put it in the IMA. I don't know.
You can put it
or not.
So, Dr. Lata, if you are there, you can have your camera on. I will share the screen on your behalf.
okay, madam. Thank you so much. Thank you so much.
No, absolutely. Do it. Yeah. So you have your camera on so that I can see you that you are there. Yeah.
Okay, okay.
So do you want me to share the screen?
Yes, ma'am, can you just share my PPT? I will.
Yeah, I will do that. Don't worry. It's no problem. Yeah.
Okay.
Yeah.
I'm really sorry for all the delay. The pedagogy which I'm going to discuss is case study with brainstorming. So the next slide is, this is just a report which states that 133 attacks in a year on healthcare workers, and a non-profit organization conducted the study. And they found that of the 200 incidents of violence against healthcare workers in India, past, that is during the COVID pandemic, there was around 133 incidences. So the problem here, what we are facing is violence against healthcare workers. So I just want the group members to just give their ideas on how we can address the problems of violence against healthcare workers. So because it's already this late, it's only for 2 minutes, maybe 1 or 2 points. I would like the ideas from our group members. So one of it could be what a doctor can or a healthcare worker can or should do to avoid violence. So if I can get 1 or 2 ideas on this, anyone please. No.
Dr. Harim.
It's not
Bouncers,
working.
bouncers are there in few of the hospital. They have put in Ernakulam Medical Center. They have put bouncers.
No.
I feel finally we'll come to that because it is a deterrent. They don't need to hit, they are around. You're seen with all the entertainment people, there are bouncers. And we have to charge the patients for that, as simple as that.
The problem with bouncers is maybe certain areas can be covered, but how about when the doctors or nurses are all alone and they have no help available? That's where the problem arises. I can see a good answer by Dr. Rafiq, RCA and Papa. I think we are making more scientific by find out what is the reason and why not do the corrective action and preventive action. Thank you, Dr. Rafiq. That was a very good point. Dr. Rafiq.
What is
Yeah,
that?
good.
RCA and Kappa?
Okay.
So RCA is like you try to find the root cause. Why did the violence break? Why did
Root
that
cause analysis.
Yeah. Kappa is corrective action and preventive action. What can be done to prevent it and what correction can you make? Yeah.
So the next aspect, what I would like to get your ideas is on what the administrators should do. I think only these 2 points for time being will cover. Maybe 1 or 2 ideas on what the hospital administration can do for violence against healthcare workers.
From cod blue or cod violet,
Good, purple.
purple.
Yeah.
And a common buzzer.
CCTVs.
Yes. So good.
Enhance all the security measures.
Do a dry run.
Right. Yes.
Mock drill.
Okay. So thank you, team members, for your active participation. I'm just going to my presentation. So what now we had was a very micro brainstorming session because we of the time constraint. So brainstorming is a group solving problem method which involves spontaneous contribution of ideas and solutions. What has happened with our small activity. Next. So how to run a brainstorming session? So first we have to identify our goal. So that's how our problem we have identified. We have to gather the right team who can give the correct ideas and feedback for that. We have to set the stage. It could be all the group members meeting together or like how we are doing it online. Then we have to pick a qualified facilitator. As of for this session, myself was the facilitator. I don't know how qualified I am. But the facilitator is one who sees to it that the discussion is going on in a smooth way. Make sure everyone participates and don't stop when the meeting ends. We have to follow up with the ideas and build on it. So the do's are, we have to, here it's focus on the quantity. It's not the quality of the ideas. It's the maximum number of ideas which we get in this discussion and not how, what, it could be bizarre ideas also, but it's just the quantity of the ideas which is important. And we have to encourage wild ideas. And once you get the ideas, we have to combine and improve those ideas. At the same time, we have to stay focused. That is the goal or the problem. We should not go away from that. Time box activities should be done, one conversation at a time. And again, because we are getting a lot of ideas, documentation should be there. So in a group, actually for documentation itself, we have to keep a person who's going to document all the ideas. And after all this, we have to allow the reflection time, and then we have to act on those ideas and follow up. Next. The don'ts are do not criticize. No matter whatever the ideas, it could be very wild ideas. Nobody has to be criticized in brainstorming session. Do not be too rigid, but at the same time, we should not move away from our goal. We should not let it out of your control. No idea is bad idea. So we have to document all the ideas and do not be judgmental when you hear all the ideas. Advantages are it allows people to think more freely and generate innovative ideas. And idea building is when the group members, they start giving ideas. So when we listen to one or two ideas, we can build up more on those ideas, and there'll be better chances of getting solutions. And team building, again, when after a brainstorming session, we get all the ideas, then with that, we with a consensus, when come to a solution, it's not the solution because of a single individual. It's the team on the whole that has worked towards it. So it's very good for team building. And again, when we do a brainstorming session and we generate a lot of ideas, we have to list the ideas. And for future other activities or similar purpose, we can use those that list. And another important advantage is in more ideas in a shorter amount of time. So if you want a immediate idea for a problem which we don't have, we can go with a brainstorming session where all the brains work together and we get a lot of ideas. Disadvantages, again, not everyone actively participates. Some of them may be left out, or some of them who are participating over actively, they may overshadow the others. Again, difference of opinions may create rift in the group. Peer pressure is another thing where other people persuade you to act and think in a specific way. So when you hear the ideas of one or two members, you also tend to have a tendency to thinking that that is correct. So that's a disadvantage. And we have to see that it doesn't transform into chaotic scavenger hunt if the proper agenda and briefing is not done. That is, we are not briefing about what is our expectation of this brainstorming session, then it could become chaotic. Next. Uses to create interest of people. Again, to create consensus. When you get a lot of ideas, we all can work on it and create a consensus and get to a solution. And finding solutions for some problem for which we don't have ready-made answer. So we can just go with a brainstorming session and get a lot of ideas, and maybe we can get an answer for our problems. And this can be used as an ice-breaking activity also. Thank you.
Thank you, Dr. Lata, for a very interesting presentation. I think very briefly, you have covered almost everything related to brainstorming. In a physical setup, one good idea of how do you brainstorm is if you have stickies and a poster. So where you ask people to just write their ideas about that. There you don't have to identify who has written what idea. So there that hesitation that my idea will be criticized or will be considered wide actually goes off, and people come up with more ideas. In a physical setup, of course, in online, you would know who is responding and who is giving that idea. But in a physical setup, if you just give them colored stickies and ask them to write their idea and put on the poster or on the, on a board, then they will give, all ideas and whatever that comes together. But that's a very good way of finding solutions to the. Thank you, Dr. Lata. I think any questions to Dr. Lata? Okay, I think I'll not hold you further. It's already 11:15. I think we have crossed the limit. I'll close it quickly and I'll share the feedback for the session. So the feedback is not for the presentations, please remember. Feedback is on the topic, understanding patients' expectations. That's the feedback. I'll share it with you. Please do the feedback by tomorrow morning. Should I close? Yes, Dr. Paul, please.
Yes, madam. What is the most convenient time we should call for discussion regarding our pedagogy presentation?
So usually share your presentation with me if you think you can prepare the presentation and then you want to discuss. There are both ways. Okay. One, in case if you want more clarity, if you want to talk to me first, you can talk to me first and then send the presentation and then we talk again. Or you make a presentation and send it to me. Normally, if you message me as soon as I get time, I normally say we can connect at this time and we can talk.
The time, I mean the daytime or the evening time? Or
I'm normally not very rigid about it. In case if you say whole day I'm not available, I can only talk in the evening. So even if I'm free around 8 o'clock, I'll say, okay, we can talk. It's just a 5-minute discussion, not a very long discussion.
Okay, thank you.
Yeah, once you share the presentation, then we can fix the time to connect. Thank you so much, everyone. God bless you all. Thank you.